Hello, everyone, and welcome to today's webinar, which is co-sponsored by the Northwest ATTC and the Western States node of the NIDA Clinical Trials Network. My name is Meg Bruner, and I'm with the Northwest ATTC, and I'm going to be hosting this thing today for you guys. We're going to get started in a minute, but first I just wanted to give you some information on how this is going to work. First, we'll be posting the slides from today and also a recording of the webinar on the Northwest ATTC website later this afternoon. You can see the URL on the bottom of the screen there. You'll also get an email after the webinar is over with a link to a survey about it that we would really like you to complete, and you'll get a second follow-up survey in 30 days. Your feedback is really important to us, so thank you in advance for filling those out. In about a week or two, you'll get another email from us, sorry about that, that has instructions on how to obtain your CEU for this session. So if you stay until the end of the webinar, you'll be eligible for 1.5 NADAC credits. Please feel free to ask the speakers questions at any time during the presentation using the chat box, and then at the end I'll read your questions to them so they can respond. Okay, so let's get started. Our two speakers today are Dr. Andre Jones and Dr. Carl Seashore. Dr. Jones is Executive Director at UNC Horizons and Professor at the Department of Obstetrics and Gynecology at UNC Chapel Hill. She's an internationally recognized expert. Oops, I was supposed to advance the slide here. Hold on. Let me see if I can actually advance the slide. There we go. There we go. Hey, look at that. Okay. She's an internationally recognized expert in the development and examination of both behavioral and pharmacologic treatments for pregnant women and their children in risky life situations, and has written over 195 peer-reviewed publications and also authored 2 books, including one on comprehensive care for women who are pregnant and have substance use disorders. Dr. Seashore is a professor of pediatrics in the Division of General Pediatrics and Adolescent Medicine and is soon to be the pediatrician in residence at UNC Horizons. Very cool. He is a general academic pediatrician with interest in quality improvement, newborn care, ambulatory pediatrics, and informatics. Dr. Seashore has worked extensively with the Perinatal Quality Collaborative of North Carolina on projects relating to newborn care delivery across the state. They'll be speaking today about research and clinical perspectives on providing comprehensive care for pregnant and parenting women with opioid use disorder. So Dr. Jones, I'm gonna transfer control of the screen over to you. Okay. And so just click on the slide and then see if you can advance the slides. And just a reminder, it might take a second.
I'm clicking.
Okay. Doesn't seem to think you have clicked on the screen.
That's interesting.
Oh, but I just saw the mouse move, so that seems like a good sign.
So I'm moving the mouse and clicking, and it worked well before. No?
Let me just take a look at the.
Okay.
I think you just did it.
Well, we just moved the mouse like I don't. Okay, I guess that's the way we're going to do it. All right.
Okay.
Ooh, now I can't move back. All right, so we're just going to go ahead and start. Sorry about that. For our disclosures, we really don't have any disclosures. I guess we're not that popular with drug companies, which I guess is a good thing. In terms of the FDA context, I think it's really important that we at least acknowledge that both methadone and buprenorphine that we're going to be talking about today have historically been labeled previously the FDA used categories, and it was category C, basically recognizing that there are animal reproduction studies that have shown adverse effects on animal fetuses, and that there weren't adequate, well-controlled studies in humans. So basically use these medications if the benefits outweigh the risks for pregnant women. And of course, now the labels have been changing on opioid medications. And so it's important to also note that as May of 2016, that the FDA is requiring a boxed warning around the risk of neonatal opioid withdrawal syndrome, which we often know as neonatal abstinence syndrome, for a variety of opioid agonist medications, including methadone and buprenorphine. What's also important on this slide is that we know that medication-assisted treatment in the form of methadone and buprenorphine are really our first-line therapies. And if you look at the labels for both methadone as well as the single product and combination product, they all talk about pregnancy, and they all talk about lactation and postpartum. So again, use these medications like you would other medications where the benefit needs to outweigh the risk to the mother and the fetus. And then finally, I would draw your attention to a 2014 paper published with an FDA consultant where these medications are not to be considered off-label use, or in other words, they're on-label use. Reading the product inserts will be very helpful for explaining that. Okay, so we have 4 objectives that we're going to accomplish with the time that we have. So we want to look at the historical and current factors that can help us understand the current opioid crisis that we have in this country, particularly for women. We'll be looking at the new SAMHSA recommendations that were published in February of 2018 about how to care for pregnant women and their children. And then we'll also be looking at identifying factors that drive neonatal abstinence syndrome, also known as neonatal opioid withdrawal. And then the final objective that we hope to accomplish is looking at different elements, at least 3 elements that you can name, that are common themes around model programs that we know work to produce positive mother and child outcomes. So taking a historical look, which I think is really important, otherwise history begins to repeat itself, we know that this isn't the first time in our country that we've had an opioid crisis. So if you look carefully at the literature, the first time it was acknowledged was in the 1800s, and the vast majority of people that were using opioids were women, and they were obtaining their opiates from well-meaning providers that were providing them opiates for things like menstrual problems, pregnancy problems, anxiety, depression, et cetera, et cetera. It was really in the 40s and the 50s where we started to see negative and stigmatizing language used around women who were using opiates. There's a famous book called The Road to H, where they basically describe women that were using opiates and who especially became pregnant as unloving, as selfish, as self-indulgent, as non-compliant, and those sort of negative words and negative stereotypes, unfortunately, have really stuck. So then moving forward to the 70s with the Vietnam era, and we had another rise in opiates in this country, and that's when the National Institute on Drug Abuse in the early 70s, one of their first initiatives that they focused on was opioids and pregnancy. And there were some really interesting demonstration programs that happened there that we actually have some long-term outcomes of babies that were prenatally exposed to opiates, including methadone. And then finally, of course, in this current time, we have the opioid epidemic that, again, was in part stemmed from great access to legal prescription opiates. So looking now at where we are, there was a presidential commission on combating drug addiction and the opioid crisis, and one of the main taglines that came out of that was an acknowledgement that every single day, 175 lives are lost in terms of drug overdose in general. Different estimates are around, but around 120 individuals every day die attributed to opiate-related causes. And so that's, if you think about this incredibly sobering statistic, that's like an airplane every single day falling out of the sky. And if an airplane every single day was falling out of the sky, perhaps, the response would have been more immediate. The good news, of course, is that there is a tremendous amount of state, local, and national attention being given to this, and a lot of funding is being put towards solutions. And so the last part of the slide that I'll draw you to is the numbers of individuals who die each year, and you can see where HIV has gone up and then obviously dramatically gone down in the last decade, whereas car accidents and guns have remained relatively stable, whereas drug overdoses have crept up. And so when we look at a gendered view of opioid use in the United States, or misuse in the United States, you can see that in the far left hand, they're all the opiates. Males, the light red and dark red, are males in 2015 and 2016 respectively. So you can see that these are the age-adjusted rates of overdose deaths. So you can see for opiates, all opiates, prescriptions, opiates, as well as for cocaine and psychostimulants, that if you look at sheer numbers, males more often die than women do. What's not in this number, of course, is the sensitivity around, from 1999 to 2017, the death rate from drug overdose among women aged 30 to 64 has dramatically spiked up 260%. So I think we need to be paying close attention to both genders and not forgetting women. This triple wave epidemic is something that has been talked about, and I think this slide nicely shows that from the CDC, just in terms of, it used to be that we would have, a stimulant epidemic and that would go down, and then we would have a sedative epidemic and then that would go down. Now we're getting waves that are kind of tidal waves crashing over us with, you can see the rise in what's called painkillers here, and the concurrent with the rise in heroin, and then of course now the fentanyl and fentanyl analogs in terms of death. And so each one of those, while they're all opiates, still the context, I think, in which individuals are getting these and using these and dying from them do tend to be different and warrants unique approaches. And particularly for women, because this is a focus on a talk that's focused on women, there's been an overall 48% rise in death rate in women. And in large part, this is women in rural America, and it's attributed to both suicide and overdoses. So we just really, there can't be enough emphasis placed on the need to really focus on women and what we can do to help protect them and help them have better health outcomes. And so when thinking about women and opiates, we know from the literature that women compared to men are more likely to report chronic pain. We are more likely to be prescribed prescription pain relievers, kind of like the 1800s. We're more likely to be given them in higher doses and for longer periods of time than our male counterparts. And there was also data to show that we were less likely to receive naloxone for an overdose. And hopefully that has begun to change with training in first responders, so that hopefully that gender gap is starting to change. So this is an interactive part of our webinar with thinking about how you define addiction. So if you could take just a moment to write in the chat box how you all define addiction, I'll read a couple of those responses. Oops. Do we have chats?
Not yet.
No. Oh, 2 new messages. All right. So, so an illness that is inherited is one of the answers. Use despite negative consequences, chronically relapsing brain disorder, use despite negative consequences, compulsive behavior despite negative consequences, loss of control, chronic illness or condition, pervasive dependence upon a substance, dependent on something, and substance use that impairs functioning in multiple life areas. Fantastic. Yes. So I think all of those responses tell me that you're very familiar with the topic, and also too, it also says something about the sort of multimodal issue that that this illness is. If we were to look at the DSM-5, the DSM has changed our language. It used to be abuse and dependence, and now they've changed it to be a use disorder that is a continuum from mild to moderate to severe. And in this wheel, you can see, that loss of control, the loss of being able to fulfill obligations, the use despite health problems, those urges, the inability to, successfully cut down or stop when we want to, as well as the issues around tolerance and withdrawal. So I think, thank you all so much for adding to the discussion in the webinar. So who is at risk for having an opioid use disorder? Obviously, everybody that takes an opiate is not going to develop an opioid use disorder. And so giving guidance to providers about what do we need to be looking for. And there have been a number of papers that have been published on this topic. I just picked 2 to highlight. And so what they found is among individuals that had an opioid use disorder that were prescribed opiates, they found that the biggest risks for developing an opioid use disorder was already having another substance use disorder. And you can see there on the left-hand side that alcohol use disorder was for 41% of patients, and nicotine dependence was 29%. And then there's also the component of major depression. When we looked at another study of 4,400 patients entering drug treatment for an opioid use disorder because they had been initially exposed by a physician's prescription to treat pain, Again, it's similar data, so we can see having used a psychoactive substance non-medically before or at the same time of their opioid prescription was a big red flag, as was alcohol, tobacco, and marijuana. And that was true for both women as well as for men. So what's really important about this is when opiates are being prescribed, that you're having conversations and looking for these red flags to have additional conversations and understanding and guidelines for patients that might need these opiates to not develop an opioid use disorder. When we think about pregnant women, these are data from SAMHSA with a national survey. And you can see data from 2015 in blue, 2016 in green, 2017 in gray. And when we're looking at illicit drugs, you can see that's broken out. And while so much of our national conversation is around opiates, you can see that opiates, while they've gone up in proportion over 2015, 2016, and 2017, it's still, marijuana is actually the leading illicit substance that is reported by women to be used during pregnancy. And then, of course, that's still smaller than the tobacco use or alcohol use during pregnancy. And so I hope that opiates doesn't overshadow the conversations that we need to be having with women about tobacco products and alcohol products, and particularly with regard to vaping and those other types of inhaled products. So now I'm going to turn it over to Carl to talk about neonatal abstinence syndrome.
Great, thank you, Hendree. And so as we think about the epidemic, particularly the opioid epidemic over the last decade, one of the huge impacts of that, and where it's been palpable to me as a pediatrician, is in the concomitant rise in our seeing of neonatal abstinence syndrome, also called neonatal opioid withdrawal syndrome. So you'll see the abbreviations NAS or NOWS. And so to follow the theme of sort of looking at history here, how has that been defined historically? So you'll see the first reference there on the bottom of the screen is from 1975, and that's really when our modern definition of this came to be. And essentially, NAS results when a pregnant woman is regularly using opioids, such as heroin or oxycodone, or medication-assisted treatment with methadone or buprenorphine during the pregnancy, and so that the fetus is continually exposed to that compound or medication in the womb. And then when they're born, that continuous exposure is cut off when the umbilical cord is severed. And that withdrawal can manifest in lots of different ways. Characteristically, we think about it as 4 different categories. One is central nervous system withdrawal, in which case you might hear high-pitched crying or see irritability. If you've ever watched a news clip on NAS, it inevitably involves a screaming baby, which is perhaps not the right way to present it, but it's what we see. They can also have exaggerated reflexes, tremors, and increased muscle tone or tight muscles. Their sleep patterns are often disrupted. They also exhibit autonomic nervous system dysfunction with sweating, fever, yawning, sneezing, and some of those things can overlap behaviors that we see in normal babies or in non-exposed babies. The gastrointestinal system, as you know, has opioid receptors in it, and babies can manifest gastrointestinal distress after exposure in the womb, and this can show up as poor feeding, vomiting, loose stools. Often these babies have terrible diaper rash after a couple of days if their stools are loose. And then they can also show signs of respiratory distress. And I can recall more than one baby that I've been called to the bedside for evolving respiratory distress and other symptoms, and have been concerned about sepsis or pneumonia, when in fact it's neonatal abstinence syndrome from an unknown exposure during the pregnancy. So really a wide variety of symptoms can manifest. But it's important to recognize that neonatal abstinence syndrome is different than fetal alcohol syndrome. And fetal alcohol syndrome causes permanent structural brain changes, typically with early exposure to high doses of alcohol in the first trimester. And this has been associated with long-term behavioral and cognitive and physical outcomes in babies, whereas opioid exposure during pregnancy has not had those same associations. We also know how to treat NAS, and over the last 5 to 10 years, there's been really exciting progress in how we approach treatment for these babies and moms together. And as far as we know, these treatments don't have the same sorts of long-term effects as alcohol exposure in the womb, or even nicotine exposure with growth restriction and prematurity and other consequences of that. So as we think about the rates of NAS in the setting of our current opioid epidemic, if you look at this slide, it's the incidence of NAS per 1,000 live births, looking between 2004 and 2014. And this was from the journal Pediatrics, published just last year. And you can see that the rate of NAS has been climbing, just as the rate of opioid use and prescriptions has been climbing. And then the majority of these babies are covered by Medicaid, so the burden for this treatment of NAS typically is falling to states and the federal government. Another important thing to think about in terms of the background of approaching women with NAS is it can occur in a host of different types of presentations. So for me, when I was in training 20 years ago, it was more commonly that I would see this with either drugs of abuse or methadone. And buprenorphine treatment really wasn't available. Currently, my experience in a typical week in the nursery is that if I am concerned about NAS, it's in a woman who's engaged in treatment through our Horizons program and is taking buprenorphine in a medically assisted treatment type program, although we certainly still do see illicit use, as well as prescribed medications for chronic pain. So we can have a host of different scenarios where a woman is taking oxycodone because she had a pelvic fracture during her second trimester and she has pain from that. That's a real case. Women who are in MAT and receiving medication like methadone or buprenorphine under medical supervision. Also, women are using street drugs such as heroin and others illicitly, but also women who are perhaps finding their way to some buprenorphine or methadone illicitly. So it's not always cut and dry, and it's really important to dig into the history of a pregnancy to understand the scope of risk, because the stability of the mother-baby dyad depends tremendously on whether or not the mother is in treatment or otherwise stable in her receipt of these opioid medications during pregnancy, and that's really important for management decisions moving forward. The pathophysiology of neonatal abstinence syndrome is really rooted in this deprivation of opioids for chronically stimulated receptors. This stimulates a whole cascade of neurotransmitter synthesis and redistribution that ultimately increases noradrenaline, corticotropin, and receptor activity peripherally, as well as acetylcholine, while decreasing serotonin and dopamine. So basically, you're getting a surge of all the stress hormones and suppression of all the chill hormones, to put it in lay terms. And so you can imagine that would make a baby feel pretty out of sorts when they're acutely deprived of these substances that they were exposed to in utero. Another key point that I think is really important to reinforce with ourselves and our colleagues, but also with the mothers and family members of these babies, is that newborns aren't addicted to these medications, right? They are simply physically dependent because they were exposed during pregnancy. But as Andre's interactive exercise pointed out just a few slides ago, we really think about addiction as a behavioral disease. And babies are not behaving in erratic ways to seek their next dose of medication. They're simply having a physiologic response to the withdrawal. And so it's really important to talk about that as dependence rather than addiction, and as a physiologic process that we can understand and know how to treat, rather than thinking of these babies as being addicted. And again, if you've read any of these articles in the lay press, it's not at all uncommon for the headline to read something like "Addicted Babies, what do we do about it?" or something like that. And so I've written many letters to the editor to get those changed, and I would encourage you all to do the same if you see that. As far as the substances that might be implicated in NAS, Again, the historical definition was really built around heroin in the 70s, but in fact, we've seen now over the ensuing decades that the physiologic expression of NAS can occur with other non-opioid drugs, as well as the newer synthetic opioids that we're seeing both in prescription and MAT applications today, as well as on the street. But we also see it with SSRIs and tricyclics or methamphetamine and other inhaled drugs. And so, again, a very good history of the mother's exposures during pregnancy is critical. And if we take that as folks involved with care of newborns, from a vantage point of being able to help their baby as best as possible, then we'll be more successful in understanding exactly what those exposures may be and how we therefore need to treat them. There are some other factors that none of us can control that relate to NAS manifestations and severity. One is genetics. Differential metabolism of opioids can lead to differential experiences physiologically. The most notable change about this recently is the removal of the recommendation of any codeine products in pregnant and breastfeeding women, and more careful thought given to ultra-rapid metabolizers and potential secondary exposure to baby in moms receiving those medications. So for the OB folks in the room, definitely looking at ACOG resources about prescribing during pregnancy and breastfeeding is something I'd encourage you to do. And then the other things that sometimes we can control are concomitant substance exposure. And the secondary data analysis from the mother study that showed NAS presenting more severely in babies who are concomitantly tobacco exposed illustrates this well. So when you're working with a mom, especially prenatally, being able to counsel her about things she can do to help her baby have the best possible outcome, perhaps, although it's not easy, the most impactful thing she could do while remaining in treatment on medication-assisted treatment is to cut down or eliminate her tobacco exposure. And just last week, I had a mom who did this by picking up vaping instead of smoking, with the misunderstanding that the vaping products didn't include nicotine. And so being really attentive to that in the prenatal period is important. But we do know that babies who are born to moms in MAT are more likely to go to term and have a healthy birth weight. And so that is definitely the preferred treatment course. And it's important also to know that the dose of methadone or buprenorphine doesn't seem to relate to the severity of NAS. So the mother should be on the dose that's right to treat her symptoms without a concern that a higher dose might put the baby at increased risk. So what can we do? And I saw in the chat box someone was eager to hear about treatment. So thanks for hearing about background, and we'll jump into that now. There's lots of things that we can do short of pharmacotherapy that can really improve the outcomes. And the literature over the last 5 years has been rich with papers demonstrating very specific projects that have shown success here. So one, and the one we've known for the longest, is simply having a protocol, getting the people together before you're looking at a baby who are going to be involved from OB and anesthesia, midwifery, pediatrics, family medicine, social workers, nursing staff, lactation consultants, really everybody who's going to be interacting with that family, that dyad, and creating a protocol where you talk about non-judgmental language, as was mentioned earlier, where we talk about what the assessment mode is going to be for these babies, what the room environment is going to look like. Where can they be cared for? Does your hospital require these babies to be admitted to an intensive care setting for their NAS? Or can you provide the same level of care on the mother-baby unit where rooming in has been shown to improve outcomes exceptionally well? What assessment tool are you using? Are you using the original Finnegan, a modified version of the Finnegan, one of the other opioid withdrawal assessment tools that's out there, or one of the newer tools such as the Eat, Sleep, and Console approach that was recently published out of Yale and has subsequently been validated or at least restudied at BU and in New Hampshire. Other things is what criteria do you use to initiate and wean pharmacotherapy when you start it? What is your policy around breastfeeding in women who otherwise don't have a contraindication to breastfeeding, such as HIV infection? And then what about separation of mother and baby, especially as the baby's length of stay goes longer than the mother's postpartum stay, and the baby may need a longer period of observation. And so thinking about all of those factors are things we can control as pediatric providers that can improve babies' outcomes. So here's the paper from Yale. This is Matt Grossman's work. This was a cohort of 50 consecutive methadone-exposed infants managed in their inpatient unit. Their Finnegan scores were recorded per historical routine, but they were managed using this Eat, Sleep, and Console assessment approach, which, if you've not heard of that, essentially is instead of measuring the 28 items and giving a numerical score to those and adding those numbers up and making a treatment decision based on those numbers, instead, it encourages focusing on functional outcomes in the baby, i.e., can they eat an appropriate amount for their age? Can they sleep for at least one hour uninterrupted without waking? And if they're fussy or irritable, can they be easily consoled, either by the mother or other family members who are present, or with additional interventions recommended by hospital staff? That might be something as simple as dimming the lights or turning off the television. It might be finding the right swaddling technique or using a pacifier. It might be increasing the caloric density if the baby's not breastfeeding of their formula to make eating a bit more efficient. These are measured objectively as greater than or equal to an ounce if they're bottle feeding, again, undisturbed sleep for an hour, and consoled if they're crying within 10 minutes. So what Dr. Grossman and his team then looked at was the treatment decisions that were made using their ESC approach, and they compared those with the predicted treatment directions had the FNAS scores been used. And using the ESC approach, they had 6 infants who were treated with morphine compared to 31. So 12% versus 62% of the babies in this particular cohort were treated using this novel approach, and they had no readmissions or other adverse events reported with this cohort. So a really provocative but also encouraging study validating this novel ESC approach. And speaking from our own experience here in Chapel Hill, we've been using this approach for about 18 months now, and very similar to Matt's published work, and ours is in press, we have substantially reduced the amount of opioid use in treating NAS, and then improved length of stay, again, with no observed adverse outcomes.
And so just to add on to that, just to think about, there's been a number of papers that have been published looking at which type of opioid medication is better to treat NAS. And it seems like my take on the literature, and Carl, you can correct me if I'm wrong, is that methadone seems like it's got a bit of an edge in winning out in terms of medication. So I didn't know if you wanted to say anything more about that.
Yeah, like I said, there's been a lot that's come out in the last 5 to 10 years. And we've seen studies looking at buprenorphine. That was a New England Journal paper suggesting non-inferiority at least, if not better. Methadone does seem to be edging out morphine from a safety perspective, but morphine still remains the most commonly used medication simply because of its ease of titration and availability. But I think that's an area where we're going to see some change in the coming years, and we should be paying attention to the literature to see what else comes out that might give a more clear guidance on what to use for both primary and second line medications for babies with more severe NAS.
Awesome, thank you. So let's take a step back now and let's really talk about what happens when women who are using substances get pregnant, because that's the most common reality that we see, is that you have a woman, she's using different types of substances, and then she becomes pregnant. And for some women, they continue to use, and for others, they don't. And you can actually see this in the national data if you're looking at non-pregnant in the dark green through first, second, and third trimester. For alcohol, for cigarettes, as well as for illicit substances, at least women are telling us that they are reducing their, the proportion of women are reducing their substance use once they become pregnant and then throughout their pregnancy, which I think is encouraging. But for some women who are using substances, become pregnant, they're not able to stop. And really, you know, I don't think I've ever met a woman who didn't want to have a healthy birth outcome. And so for those women who aren't able to reduce or stop, they likely, by nature of that substance use disorder definition that we looked at before, they likely have some type of substance use disorder. So we want to be able, because it's that sort of salient feature of continuing to use in spite of adverse consequences. So we need to be able to respond to them in an empathetic and helpful and non-judgmental way. And so how do we do that? So SAMHSA has published guidelines, as I said, in February of 2018. This is a super user-friendly document, and there are different fact sheets that can be pulled out, and I believe there are even more fact sheets now that have been coming out. And so you can Google them, you can download them. The audience is for providers as well as for lay people. And the 5 main recommendations that came out was, one is that we should not be using medication-assisted withdrawal, also known as detox, as recommended during pregnancy, and we'll talk a bit more about that. Secondly, that both buprenorphine and methadone are safest medications for managing opioid use disorder among pregnant women. But if women already are on one of those medications, you really shouldn't be switching them. So please don't switch women that are well-maintained on methadone onto buprenorphine, or the reverse. If a medication is working for a woman, don't change it. Keep her stable, because you don't want to create a period of vulnerability. A 4th recommendation was that breastfeeding is recommended for women who are stabilized on buprenorphine and methadone. And that seems to be a challenge. We need to keep continuing to repeat this message, because there's still a lot of misinformation out there. And then finally, around neonatal abstinence syndrome, there was a recommendation for not treating with diluted tincture of opium, given the amount of alcohol that's in that medication. So more about the medication supervised withdrawal not being recommended. So there's concern not so much around spontaneous abortion or fetal demise or premature labor, as was originally written a long time ago. Now, really, there have been a number of papers to show that it is possible to withdraw women safely from these medications in terms of pregnancy outcomes. But really what the concern is around a return to substance use. And so in non-pregnant adults, we know that detoxification doesn't work very well as a long-term solution for opioid use disorder. So why would we think it would work any differently in pregnant women? That said, there should never be a blanket one-size-fits-all, everybody has to do this. So if there is a decision to withdraw, because, for example, a woman says, I'm not going to come to treatment unless I'm withdrawn from all substances, and you want to keep her in care, then that needs to be a case-to-case decision. And so some guidance around doing that would be, using a controlled setting, having a really good social support and overall recovery support system and care plan, having a contract, talking through what that's going to look like for her, and making sure there's a continuous conversation during that withdrawal, if it's going to be done, that the benefits are outweighing those risks. So in terms of what ACOG is saying around treating women with opioid use disorders during pregnancy, we want to be doing universal screening. And when we say universal screening, that is a verbal tool. It is not looking for urine or using some other type of biological matrices. It's having a good conversation with a woman so that she will trust you and she'll understand what happens if she does say, yes, she has been using a substance. So giving that brief intervention and referral to treatment. And I see a lot of times that the brief intervention is sort of passed over, that it's just she screens positive and immediately there's a referral, when providers have such a powerful opportunity to talk to women and give them some really good advice, and to use some motivational interviewing, a readiness ruler, those types of things can be great interventions in this brief way. And then also just thinking about multidisciplinary long-term follow-up. So I'm going to talk more about the postpartum period, but really it shouldn't just be truly medicalized approach. We need to have social supports on board. We need to be thinking about developmental aspects for the babies as well as social aspects for mom, and then comprehensive medical care for both mom and for baby. And this slide just talks more about how screening really differs from testing, because I see a lot of that gets confused in the literature and in talks that I see. And so screening, you know, it's a cheap way of doing things. We want tools that are going to be more sensitive and not miss potential people and then rule them out later with a later assessment. And screening should be really quick and easy to use and should be well accepted by both patients and staff. And in turn, maternal urine testing is much more of, it needs to be done very carefully. There needs to be consent with mothers. There is a cost to it, so you really need to think about how much does this, how much of the benefit are you going to get for the cost? And there's also how you're going to do it, because if it's just quick tests, there's a lot of false positives, and those can have damaging negative consequences that radiate for both the mother and for the child if it's not confirmed testing. So when we ask, have you been using substances? How much have you been using? When we ask in a non-judgmental and more normalized way, each time we are seeing all women, we need to understand that if we pair that with a urine drug testing, that there are many limitations to a urine drug test. And just giving a urine drug test is not a diagnosis for a substance use disorder. We could have women that are using that don't test positive because there's a short detection window for her substance. It might not capture those sort of more intermittent binge stop-starts. It's really bad for detecting alcohol use unless they've used a lot right before they come in. And if for our prescription drugs and opiates, we have to be really careful because depending on the type of panel and the testing that's used, it doesn't capture all of the different types of substances that could be used. When thinking about doing this type of urine testing, we really also need to be thinking about the ethical issues. And there's two different cases. One in 1962, addiction was finally recognized as an illness by the Supreme Court, as well as in Ferguson versus the city of Charleston in 2001, women couldn't be tested without their knowledge or consent because that was a violation of the Fourth Amendment. And I can tell you there are hospitals out there that are continuing to do this, and that's really dangerous for both the mother as well as for the child. I also hear continuously about a lot of punitive measures, and you know, if punitive measures were able to really be a good a way to address the opioid crisis that we have, we wouldn't have an opioid crisis problem. So punitive responses really don't decrease drug use in pregnancy. In some places, they can actually increase it with women being scared to seek treatment, being scared to seek prenatal care. It can create unnecessary child welfare involvement and concerns around that. It can disrupt this really critical period of time of attachment for mom and for baby. And then certainly there are long-term consequences for women being convicted of a drug-related crime. They can't get housing. They can't get a job. They can't get financial aid. They can't get help with educational opportunities. So we really need to be treating this as a health issue and putting those supports in place rather than punitive issues. In terms of capacity and treatment in this country, again, piggybacking on this punitive approach, a lot of times we'll see a punitive approach with not one single dollar increase for treatment. And we know that already, still to this day, we have underfunding of treatment centers. And this was a study that Stephen Patrick and colleagues wrote that said that only 15% of treatment centers offer specialized services for pregnant women. And this can be even worse in rural and poor areas. So we really need to be doing a much better job with how to get treatment to the right people. And it shouldn't just be prenatal care or substance use disorder treatment in and of itself. It really needs to be integration of care. And so, for example, at Horizons, we have a model of care where pregnant women and postpartum women come in. They see their provider for physical health care and for their medication-assisted treatment if they have an opioid use disorder. And they also see a peer support specialist and a therapist all in one bundled visit. And that we've seen creates only a 5% low birth weight and 5% prematurity rate at Horizons for at least the last 6 years running, which is pretty remarkable in a high-risk population of women. What does our World Health Organization say about recommendations in their guidelines? These were published in 2014. There are a total of 18 guidelines. The one that I will point you to is the one that talks about number 11, that pregnant patients with opioid dependence should be advised to either continue with opioid maintenance therapy, either methadone or buprenorphine. And this is really the first guideline that ever came out to say that buprenorphine or methadone can be used, and it wasn't one over the other. In terms of the medications that we have available to us, if you look at the product inserts that are approved by the FDA to go with the medications, you will see that methadone, buprenorphine alone, as well as the combination product, all talk about pregnancy, postpartum, and lactation. So they all can be used during pregnancy. And we've been getting a lot more data on the combination product that I'm not going to go over, but I'm happy to have conversations with people about that. In terms of, and I'm sorry, the bullets kind of drifted down the slide here, but really, both methadone and buprenorphine have advantages and disadvantages. The advantage that buprenorphine seems to have over methadone is in terms of lower risk of overdose deaths. We have fewer drug interactions, and it's also easier to get in terms of an office-based treatment. There are also disadvantages, and so certainly around induction, that can take some time to do with methadone as well as with buprenorphine. And then the other piece that the guidance did talk about was in terms of buprenorphine and methadone might not be right for each individual patient. And so it really needs to be an individualized patient discussion to see what their preference is and which fits best for them. These were data that Carl already alluded to, with the idea that in looking across women who had been treated with methadone or buprenorphine and looking at NAS, what a driving factor of the NAS was not the medication they were on during pregnancy, but how much they were smoking. And so you can see in these graphs that categorizing women by non-smoking, below average, average, or above average smoking, there's a really clear dose relationship between worse outcomes with women who, the more they smoked, the worse outcomes they had in terms of more morphine to treat the NAS that their babies had. The babies stayed in the hospital for a longer period of time with the more cigarettes smoked, and their birth weight was lower too with the more cigarettes that they smoked. I think it's important that we talk more about this fourth trimester or postpartum. It's such a critical period for mom and for baby, and oftentimes this is when treatment ends. I hear so often that 6 weeks postpartum and all of the care and support that women have been receiving, it just kind of drops off to nothing very quickly, when actually this is the most critical time. Babies are not sleeping through the night, they're going through feeding, growth spurts, and so we really need to be doing more for mom and more for baby. And there's a lot of issues around insurance being lost at this time too. And I think this is in part what driving this maternal mortality that we see that's increasing on our national basis. If you look in 2000, we had 18.8 per 100,000 live births, whereas maternal mortality was happening, and that's continued to eke up to 23.8 per 100,000 live births. And this is a really concerning issue. And there are multiple driving factors for this, including overdose, including suicide. I think the loss of Medicaid coverage by 6 weeks postpartum might be a possible driver of this, as well as sort of the way that some people are being treated during pregnancy for their opioid use disorder with detoxification. So this study was published in 2014. I think it's really startling that they looked at data from 98 to 2009 and found that women who used opiates during pregnancy had higher rates of depression, anxiety, and chronic medical conditions compared to those that didn't use. But most concerning was that this last line down here, with women using opiates, were 4 times more likely to have a prolonged hospital stay and almost 4 times more likely to die in the hospital before discharge. So this just really tells us that we have to have better protocols to help our medical facilities be able to engage women who are using opiates or in treatment for opioids or in active addiction, to help how to get them the help that they need and how to be able to best respond to them to keep them safe. More about pregnancy-associated deaths due to drugs. These data are from Texas, Maryland, Alaska, Georgia, and Virginia, and you can just see that the overdoses are playing a concerning role. Looking again nationally across the data in terms of the divergent paths. So from 1990 to 2015, the number of maternal deaths per 100,000, you can see here, this is even more recent data into 2015, which is, it's eked up now to 26.4. And you can see that we're going up as many of other countries that you would think we would be equivalent to are going down. When looking at the different states, you can see that California has done a really great job actually of reducing their maternal death rate. And in part, that's because of the more comprehensive care that they are providing to patients. So now that we've talked about sort of that fourth trimester, let's think about what are the long-term outcomes of children that are prenatally exposed to opiates, because that's something that we get a lot of questions about. And I think that the literature is still very much out there. There's a lot of, so we don't have any type of firm conclusion. We have a lot of data from the 70s, and we're getting some more emerging data now. And there have been a number of NIH calls for proposals, so hopefully in the next 5 years we'll have even better answers than we have now. But when you're looking at the literature, this is a guideline of what to be looking for. So there's a lot of papers out there that do a very poor job of defining who has been actually prenatally exposed and prenatally exposed to what. There's a lot of over-attribution just to opiates when there's a tremendous amount of background benzodiazepine and alcohol use and exposure. What type of comparison group are we looking at? Were the assessments masked? And this is a critical, important point, because if you have assessors that know the background of the children, there is bias inherent in the way the assessments are done. And there's lots of matching and statistical and inferential issues that we could talk a lot about. So just be very cautious and thoughtful when we're looking at this literature. The data that we have that were blinded assessments comparing methadone and buprenorphine outcomes up to 36 months were published by the Mother Group, of which I was a co-author. And we had 96 children, and we looked at, did it matter if methadone versus buprenorphine exposure? What were the cognitive behavioral differences, developmental differences compared to the normative norms that we have on the tests that we look at? We looked at this data inside out, upside down, backwards, and we really didn't find any patterns of differences between medications or between the children compared to the norms. So I think that's somewhat reassuring, although we need more data. And so I really think that it's important, as we're looking at this and focused so much on long-term outcomes, that we really remember the past. And Deborah Frank wrote a beautiful article in JAMA in 2001 that looked at cocaine use and prenatal exposure. And she did a very thoughtful review of the literature. And I just think that this quote here from her is really important, that, you know, with all of the media hype around cocaine exposure, she really didn't find these toxic developmental long-lasting effects 6 years out. And so I think we just need to be very careful and thoughtful, because this label of being prenatal opiate exposed or an NAS baby, which I don't like that term, has radiating, damaging long-term effects for the children as they go through life. And I'm going to turn this over to Carl.
Great, thanks again. So in thinking about the factors that mold long-term outcome in these babies, many of whom are exposed not only to opiates but other substances in utero, is what does that postnatal period look like when growth and development are occurring at such a rapid pace in the first months and years of life. And so one way to think about that is through understanding attachment and understanding that securely attached infants really are going to have a better baseline capability to self-regulate and find safety when they need it. So a child who has a secure attachment to their mother will think, I'm hurt, I'm going to go get my mommy and she's going to make me feel better, right? And the flip side of that is children who've had insecure attachment develop what's called this internal working model, where they fear or know or are concerned that a caregiver will be unavailable or non-responsive when the child needs help. And that can create sort of a vicious cycle of maladapted stress response systems in children. And so much more so than potentially the actual substance exposure during prenatal brain development is what's going on in postnatal brain development and what can we be doing to support the optimal mother-child dyad relationship to take advantage of the neuroplasticity of the brain in early childhood and help foster those secure attachment and healthy adaptive behavior systems. And when we think about non-secure attachment and substance abuse, there's a lot of threads that go through that sort of situation that I think highlights some of the behavioral and other problems we can see in kids who've grown up either in an environment where substance use is occurring or who were potentially exposed in utero. And so we know that having been abused as a child yourself is an important risk factor for whether or not you might abuse your own children. And people older than I are more likely probably to have been spanked as children, but that's something that started to change 40 or 50 years ago and unfortunately is still finding its way towards change and hopefully being eliminated as a common practice. We also know that women who are in treatment for substance use disorders have an astonishingly high rate of abuse or neglect in their own childhoods. And that maternal substance use is associated with child maltreatment. So it's sort of this cyclical pattern of abused in childhood, more likely to engage in substance abuse. Because of that, if untreated, more likely to neglect or harm your own child. And that continues generation to generation as those children grow up exposed to the traumas of substance abuse in their own childhoods. These women also very understandably have this high incidence of hostile attributions maybe to their own children based on their own experience as children. And I would also say potentially to caregivers, because sometimes we've not been the best allies for women when they come seeking treatment. And many women today who have opioid use disorder developed it in a doctor's office or a dentist's chair or in some other medical environment. And so the impact of that on trust is something we shouldn't overlook. And this essentially can formulate not only the parent-child relationship and imbalance there, but also the doctor-patient relationship. And so I think it's really important to be attentive to the risk for maladaptive attachment that these women can have and the importance of disrupting that cycle in protecting the next generation. So if we think about this from a neurodevelopmental perspective and how the experience of trauma, especially early childhood trauma, impacts development, kids who are exposed to trauma or neglect in early childhood, instead of having that organizational structure where the cortex and our cognitive ability and concrete and abstract thought are the most developed area, in fact, what happens is you have maladaptation of the limbic system and overdevelopment of the midbrain, which is sort of your fight or flight center, where you're constantly being chased by a lion and having to run or jump or hide or do something to escape your own death. And so if you think about babies growing up in an environment where they don't have that positive reinforcement and sense of comfort and trust and safety, their brain grows in such a way that it becomes harder for them to do those things, and their reasoning and judgment capacities can actually be impacted in the long term.
So
I'll give it to Hendree for this one from the last study she talked about.
Yeah, so just thinking just in terms of not only about the babies that we're talking about, but also for our moms themselves, because so many of the moms, at least who I get to work with, about 90% of them have sexual, physical, and emotional abuse that started as children and that have been continuing through adulthood. And so I think it's just really important that we need to honor and understand the trauma that moms have had so that we can better understand how to prevent and work with any type of trauma exposure that the child has had. And the more that we can have that healthy attachment, the better it will be. That said, there is no one-size-fits-all treatment approach. And so I think it's really important when we're thinking about substance use that there's a continuum, right? So we can have people that are using substances that don't have problems. It's when you get into the mild, moderate, and severe substance use disorders, those are the individuals that we really need to be focused on, unless we're concerned about sort of preventing that use for becoming a use disorder. And so the wonderful thing about treatment is that the ASAM has given us these placement criteria so that we can better fit the type of substance use disorder to the type of treatment response that's needed. And so because sometimes people get really focused on only residential treatment for women who are pregnant and using substances, when in fact there are many different types of forms of treatment that women can benefit from. And I put this slide in here. It's old, it's from 1993, but it is still incredibly relevant because we know what to do. We've known how to really start to respond to women since the 70s. And in 1993, this was the second tip that was published by SAMHSA. And you can see this model program has outreach services, laboratory, it's integrated care, it's social work, it's follow-up, it's diagnosis, it's case management. So all of these things are still incredibly relevant today in terms of having integrated and comprehensive care. These are things that work. And thinking about the NIDA principles of treatment, we can see here this is for non-pregnant individuals, and yet this can be incredibly relevant for pregnant and parenting women too. So it's a whole conglomeration of different services that are the biopsychosocial that are really important for being able to change behavior and maintain those changes in behavior. And so Horizons, I just wanted to highlight this as a model because we do work with about 50% of our women are pregnant. The other 50% are parenting when they come to us. And I think one of the things that makes us unique is, or makes what we do work well, is a uniformed philosophy of care that is informed by both a social learning approach as well as a relationship and empowerment model. So thinking about how women are getting to your services, do they have childcare? Childcare is such a huge issue for our women, and sometimes they have to choose between coming to treatment or taking care of their children. So those barriers, again, were talked about in 1993, and we're still talking about them now. And we really need resources put to that because that is such a key part of the sort of connective tissue and glue that helps treatment work. Being able to help get women back on their feet in terms of getting them the educational opportunities that they might have missed out on, having them learn how to get a job and then keep a job is really important because they're two different set of skills. Carl already talked about that sort of parenting and early intervention piece that's so critical, being able to screen and assess children that have had that sort of starting out in somewhat risky life situations and being able to then quickly respond with the care that they need. And then obviously having psychiatry because about half of our women have some type of mood disorder. And then having that continuum of care with residents and outpatient care, and of course in the backdrop of medication-assisted treatment opportunities for women. And I think when we think about what works, we have to also look at our language that we use. So this is on the left-hand side is the stigmatizing language, and the preferred language is on the right-hand side. And the idea of crack baby should be just like gone from anybody's language vocabulary, that we really need to be talking about the substance exposed infant, and also thinking about how we talk about urine samples. So the idea that urines are dirty or clean, we would not ever say that someone who has HIV has a dirty blood sample for HIV. So why do we do that with individuals that have substance use disorder? And when we can change our language, that we can actually show that we can have better, more positive outcomes, at least in terms of retrospective record reviews. That's been shown. And so there are other models that are out there and resources that are out there. I'll give a shout out for the SHIELDS program. I think there was somebody I saw on the participant list. So if you'd like to write in anything about your program, that's a wonderful true family program. Dartmouth and New Hampshire and Vermont, they have had a CHARM collaborative, and Dartmouth with the hub and spoke model of care. So there are many different fantastic models of care out there that all have the same mission of improving healthy moms and healthy babies and having a more continuum and integrated care standard. And then I think I also put this little map in here just in terms of knowing what the resources are in your area is also really important. And two, like having an integrated care, somebody just wrote and said, could you speak to the utility of a plan of safe care? And I think so much is how that plan of safe care is actually conducted. I can tell you in the state of North Carolina, we've worked really hard as a state to have children that are born known to be substance exposed, that there is a referral that happens rather than an automatic triggered response by Child Protective Services, so that there's an opportunity for screening out those moms and babies for which just because you have a substance exposure doesn't mean that mom is unsafe to care for that baby. And I think that the plan of safe care, again, how it gets rolled out really becomes a larger part of a recovery-oriented system of care for families with obviously mom and child in the center, surrounded by a variety of clinical treatments. But there's more than this, just that. There needs to be clinical supports and community supports put in place so that when mom leaves treatment, she has an opportunity to stay well and to not have to get as sick as she was to meet criteria to come back into treatment. So what can we do in terms of recovery checkups? What can we do in terms of more peer support networks? What can we do in utilizing all of those public-private partnerships to help people stay well? And so what can you do? There's on the individual level, there's so often that we hear about negative things that happen in terms of the bad stories that happen when there are just as many recovery and success stories. And so for you to be an ambassador and tell those stories of recovery, when you're thinking about care, to really not pit mom versus child, but it's mother and child and what's going to be best for both of them. There are great toolkits from a number of states, as well as from SAMHSA that you can look at. And then on a structural level, enough can't be said about responsible prescribing and education for all types of providers, from dentists to social service to law enforcement. Anybody that is going to interact with a woman of childbearing age, I think really needs to be trained on kind of that SBIRT model, so that there's greater access and understanding and awareness that substance use disorders can be treated and that success can happen. So just in summary, we know that opioid use disorder certainly is a concerning medical illness. It has radiating effects not only to that person, but also to those around the individual. And that people with these illnesses deserve appropriate medical care, but medication in and of itself should really only be one part of a complete treatment approach. It does great things, but it needs more. It needs a behavioral health approach that goes with it. And we need more options for patients and more access to patients. And when we provide a strength-based perspective, sometimes we have to be the people that hold the hope for the patient when they can't hold it for themselves. But if we don't have confidence and hope for the patient, the chances that they're going to get better are going to be diminished. And so we're going to leave you with this quote, and then we'll be happy to answer questions. That to treat babies for drug withdrawal, we have to help the moms too. And rather than stigmatizing moms with addiction, research suggests that a holistic approach to improving the lives of both mother and child is most effective. And thank you so much for your time and attention, and we look forward to answering questions.
Wonderful. Thank you so much. That was really great. I'm going to take control back from you.
Okay.
And we can start with questions. I saw a couple of come in that I don't think you answered yet. So one was a question about something you had said, where you had said, why is 10 minutes the range permitted before consoling a crying baby?
It's a great question, and it highlights, I think, an important difference between quality improvement-based scholarly projects and research. And the Grossman work was a quality improvement initiative, and so I can't speak to their intention, but I can assume that they arrived at 10 minutes based on consensus between the people on the baby's treatment team. All babies cry, and it's a common thing we encounter among parents, that they're concerned, obviously, when their baby is crying. But the vast majority of babies who are crying for whatever reason, whether it's they have a dirty diaper, or they're hungry, or they're tired, or it's too bright in the room, or whatever, we don't know, can typically be consoled within 5 to 10 minutes. And so I think that number was probably picked somewhat arbitrarily, but as a means to have an objective cutoff that if the baby's not consoled within 10 minutes, then the physician, the nurse, and the mother all need to be, and father, to address one of the other questions in the queue there. Mm-hmm. Whoever is involved in the care of the baby needs to be there at the bedside, assessing whether that irritability is potentially being caused by withdrawal and another level of treatment is needed. And so really that was a trigger to bring the providers back to the bedside to clinically reassess the baby, just like you would do if the blood sugar was, not responding to your insulin dose, right? You would go reassess the patient and then maybe adjust your insulin dose. And so that was really put in there as a trigger to prompt evaluation.
Interesting. Okay, so another person asked if you could discuss a little bit the induction strategy for buprenorphine versus methadone.
Sure. So with regard to buprenorphine, because it's done in a provider's office, there's typically, well, it sort of depends. It depends on the provider, but the way that you would manage someone who who is not pregnant is very much the way that you're going to manage somebody who is pregnant. So the idea is that you would have them come into your office, you would do some kind of objective assessment of withdrawal, objective and subjective assessment of withdrawal, because we don't want to be giving buprenorphine to somebody that isn't in withdrawal, because then we don't want to take the chance of precipitating a withdrawal. So they need to, usually for us, we use the CALS, which is the clinical opiate withdrawal scale, and we wait for something between 8 to 12, and then we provide the first dose. We split the dose in half in the first day, so we usually start out around 4, and then give another 4 or do 8 with an opportunity for more. The patient has to get her own prescription, and so I can talk more about that. I think that might be, it depends on what state you're in and what type of Medicaid, what's going on with Medicaid or private insurance. But we basically then monitor them, make sure that they're having a good response. We'll provide phone support if they're outpatient and they're going home. And so there's psychological handholding that happens. And our women, we've been doing this for several years and have had no problems with it. It's worked really well. And we actually have a paper under review right now to talk more specifically about that induction. But in a thumbnail sketch, that's what we do. With methadone, that would be, women have to go to a provider, an opioid treatment program. And so that induction often is done on an outpatient basis. And again, you're going to start with a minimum dose of methadone from around 20 to 30 milligrams, and then gradually increase over time. You need to be careful to not overdose or not move the dose up too quickly. But it's not that difficult. It's pretty simple.
Okay. So this next question I'm going to read to you, and then I'm hoping that maybe you can explain a little bit what the question means, because it's very clinical and I'm not sure everyone will understand the question to begin with. Okay. So it says, I see a lot of OBs willing to move to universal, verbal, and rare urine, but PEDIs, I don't know if that's pediatricians, tend to want more urine or universal urine tox on high-risk newborns. How can we sway them?
Yeah, I have a pretty clear understanding, I think, of what the questioner is getting at, and please feel free to chime in the box, Heather, if there's more clarification you'd like. But yes, I think pediatricians have been perhaps a bit slower, and in fact, there's been a lot of discussion about universal urine toxicology screening in quote-unquote high-risk delivery areas. So parts of the Ohio and Mississippi River valleys, the so-called Rust Belt, certainly northern New England. There are pediatricians wondering and publishing on whether universal screening is necessary. And I think the clearest response to that is that urine screening, toxicology screening in a newborn should be objectively determined. In other words, if you're using it as a practice, you should have clear, consistent criteria you apply to make that decision. And so that might be clinical factors during the pregnancy, or it might be that you do pursue universal screening in a high-risk area, but it should be applied consistently so that we eliminate some of the implicit biases that Andre alluded to earlier. And then the other piece of it is that how you interpret and use those results is really critical. So those results should be used to help define a treatment plan and your approach to caring for that baby, and not necessarily a safety or punitive course if that's not appropriate. And interestingly enough, with marijuana legalization, there's been a swing back in the other direction of we don't want to see these toxicology reports because so many of them have marijuana and we don't know what to do about it. And so I think it's an area that's in flux. But what I would encourage folks to think about is how you use those toxicology results, if you get them, to guide treatment rather than to guide something that would be more punitive in nature. And so if you do discover a substance use disorder with universal screening of urine in newborns, then your outcome better be to refer moms to treatment and hook them up with appropriate care rather than to just refer it to CPS and take away the baby and kick mom out on the street after 48 hours when she's been discharged. And so that requires some dialogue, obviously, between everybody on the healthcare team and clear policies and practice protocols that you follow and adhere to.
Okay, so the next question, and this might not be one you can just answer off the top of your head, but it says, can you share your top 3 journal articles supporting dual product use, buprenorphine, naloxone in pregnancy?
Yep, so please, I can't quote chapter and verse. Sometimes I can.
Yes, right.
I can definitely tell you that there's a Deblick article, one of the authors on that, and that was the first 10 babies that were born with the combination product. We've done a review of that. There are a couple of papers out of Canada, and I can follow up and send the whole list, or at least a good example, several examples. So because I don't know page numbers and things like that.
Yeah, if you sent me those, I could forward that out to everyone who is on the webinar today, if you wanted.
Sure.
Okay, great. Let's see, scooting down. Are there any resources for mother-child-centered care in Southern Ohio, Northern Kentucky, or Southeastern Indiana? And again, you might not know that off the top of your head, but maybe you could suggest where someone could find out.
Yeah, so I'm definitely, like, the Children's Hospital out of Cincinnati is done with Mary Haven. There's the Clinical Trials Network. I know that Mary Haven was a site for them for a long period of time. And actually, Teresa Wenhusen is at a CTN study that's looking at using buprenorphine during pregnancy. So I know that, and she's out of Ohio, so she would have a lot of great resources, I would expect. But I definitely know that Mary Haven was one of those centers that have been around for a long time, that has done a lot of work in terms of the Ohio. Then Kentucky, there is a PCORI study that was funded. And so, like, I know the University of Kentucky with Michelle Lothwall and Sharon Walsh, they would be wonderful resources for what's happening in Kentucky around perinatal substance use disorder treatment. Indiana, I don't know off the top of my head. I'm really sorry, because I haven't had contact really much in Indiana.
Wow, I'm amazed you knew the other ones off the top of your head. That's very impressive. Okay, next question. How does North Carolina avoid the CAPTA rule that seems to require CPS report for babies that have withdrawal?
Yeah, so we're not avoiding it, and I think I actually might have misspoken, so let me clarify what I said earlier. So when babies are born that would meet the criteria for, like, the FASD, the being born substance affected, et cetera, then there is a notification that goes to the Child Protective Service, but it doesn't automatically mean an open case. So we basically have, the way our state set up the reporting is that there's almost like a dual system, so that not every single case becomes an open CPS case, but there is a notification. And that seems to have worked quite well. So then there's a period of time where there's more in-depth screening that happens, and then the CAPTA requirements are still all reported in terms of babies that have been substance affected, and is there a plan of safe care, and are referrals made.
Interesting.
And that's going to vary, obviously, state to state, because the states were charged with operationalizing that law. And so to think about it more generally, essentially what we're aiming to do in North Carolina with these kids is refer them to early intervention, like you would with a child who has developmental delay in the first 3 years of life, rather than referring them to Child Protective Services. So conceptually, if you want to think about a model, depending on how your state laws are written and enforced, how can we get these kids services and their mother's support while also satisfying the letter of the law, and how can we work collaboratively with the different state agencies so that the mothers accept that referral as a supportive one and aren't skeptical of it as a punitive one.
Okay. I thought this was a really good question. Lisa is asking, how should we manage counseling patients on breastfeeding when provider of buprenorphine counseling for breastfeeding and other provider, often the lactation consultant at the hospital who are more conservative, differ in opinion?
Oh boy, that's the art of medicine in a question. I think it requires team building and trust and education. It requires sharing literature, whether that's primary literature or summative literature like from SAMHSA or the CDC and other agencies. One resource that I use constantly, and I work both as a pediatrician in our unit and also on our breastfeeding consultative service, is the LactMed database from the National Library of Medicine, which is also closely linked to Thomas Hale's book and now website out of Texas Tech. That is medication in mother's milk. And they have a 24-hour hotline where you can actually call. And if you look at those references, they all have that similar benefits outweigh risk language around breastfeeding with buprenorphine and or methadone. And then would specifically be able to also answer any other questions that the providers might have about other medication use. And the most common one that we see as an actual contraindication, although less so since we've revisited our opioid prescribing patterns in the postpartum period, is the total opioid use postpartum, especially for women after a C-section. And at, I think it's 30 milligrams a day, you have to question the safety of that mother's milk if mom is using a lot of opiates postpartum for analgesia. Buprenorphine in particular and methadone have been studied, and the neonatal outcomes are actually better in women who are breastfeeding while taking those medications, despite very small amounts of medication being present in milk. And so I would say go ahead to the questioner and reach out to those colleagues and start a dialogue and maybe share with them the LactMed website from the Library of Medicine or the Medications in Mother's Milk resource from Thomas Hale.
And the SAMHSA guidance document published in 2018 also has a fact sheet about breastfeeding and medication-assisted treatment. Great.
Okay, next question. Do you specifically have universal education conversations about current violence, particularly intimate partner violence with women who are both pregnant and using substances? And then it says, you talked a bit about violence, but concurrent reproductive coercion and substance use coercion from the partner choosing abusive behavior is something doctors can screen for. For example, using universal education conversations with tools like the Futures Without Violence safety card that talks about reproductive coercion.
Yes, fantastic. I'm so glad that the writer wrote that. Who was that? Emily? So thank you, Emily, for bringing that up. Absolutely. We definitely, like I had mentioned before, there's such a high prevalence of our women being involved in different types of intimate partner violence from, really starting from their first relationship and continuing through to the current one. So yes, the medical, an OBGYN care, a psychiatry visit is the perfect time to be able to really to talk about that, to ask about that, and to provide some resources to help women deal the best they can in those types of situations. So thank you for bringing that up.
Mm-hmm.
Couldn't agree more.
Mm-hmm. Does Horizons use a specific trauma or strengths-based treatment model?
So we, in terms of treatment interventions that we use for trauma, we've used Seeking Safety. We also use Stephanie Covington's work. So so anyway, those are the two examples of models that we use in group settings, and then as well as individual work. And then we also think about just sort of trauma-informed care using, obviously, the tools that SAMHSA has beautifully developed.
Great. Barbara sort of has a related question. She asked, you mentioned the conceptual models upon which UNC Horizons is based. Can you describe the main elements of these?
Mm-hmm. So the conceptual model, just in terms of like the social learning theory that we use. So again, thinking about, behavior, understanding of behavior, how behavior is motivated, and thinking about not so much from a punitive aspect, but really from, what are those rewards? We often say that treatment is really hard, and so what can we do to make treatment more attractive and engaging? So we use some contingency management in there, where a very concrete example of that is we have a donations room. And so when women complete a full dose of treatment, so that means they've attended, for example, 4 groups for the day, that gets verified, and then they can come in the next day and they can go shopping in our donations room. And so that's just one small example of how we're using contingency management, which is a behavioral theory, in practice. So I hope that I didn't cover it completely, but that just gives you an example of what we do using conceptual models into practice.
Great. Are there any other questions from anybody? If not, I think that might be it. I just put a slide on the screen that just notes that next week the NWATTC is having another webinar if you're interested, that's about compassion fatigue among human services professionals, and you're all welcome to register for that if that sounds interesting to you. Thank you so much to our speakers. This was really, really great, and great audience as well. Always fun when people are really engaged, so thank you so much for that as well. All right, I think that's it. Thank you.
Thank you
all very much.
Bye.
Bye, everyone.